Okay, so we're recording this. Got it. Okay, so basically this part 3, practice diary by verbose calibration by our department. I would like to thank Prof. Azida as the head of this session today, helped by Ying and Prof. Rusdiani and a few others. So basically, this is a joint effort. So I'm going to give a bit of the overview of the Masters of Family Medicine program. I think all of us know about this, but just more of a revision. Okay, so the candidate they are sitting for the part 3 exam. Basically, they've gone through all this phase 1 and phase 2. Phase 1, basically year 1, they did the hospital-based rotation involving all the major postings, medicine, pediatrics, and ONG. And then they should have passed the exam before joining year 2, phase 2, doing small postings, basically minor clinical rotations, again hospital-based in year 2, all the psychiatry and everything listed there, basically, including the geriatric, infectious disease, and even including elective. And in year 3, basically, they're really starting to have the feeling of family medicine clinic together in campus, plus the clinics under the Ministry of Health. And at the end of year 3, they set for the part 2 exam and should have passed before they enter the year 4, and where the posting will be entirely at the Ministry of Health clinic with the report from supervisors as well. Okay, and for the exam, part 1, theory constitutes 60%, 200 SBA questions. They need to prepare anyway. And then clinical, 40%, constituting 12 OSCEs. And for part 2, theory only 40%, 100 SBAs and 30 KFQs. And the clinical is 60%, where they have the 4 modified long cases, LOSCE, and 10 short OSCEs. And then part 3, the one that we're doing today, for calibration, is basically practice diary. And we have the clinical practice and practice management, the 2 components. Okay, so what's the objective of our PD by verbose? Basically to assess the knowledge, attitude, and skills in areas relevant to family practice. This is clinical practice and practice management. And this is based on the work that's been done by the candidate at the health clinic, and based on the 60 cases that they have prepared for the exam. And the format of the exam, basically we've got 2 panels. Panel 1 will focus on the assessment of practice management, skills in short-term care, proficiency in prescribing habits, and prevention. And panel 2, again, to start with, will test the candidate on the practice management, and then skills in long-term care, proficiency in using investigations, and ethics. And each panel will last for 30 minutes. So, and it's supposed to be 2 different panels, independent marking, okay? And so basically this is a summary of the practice diary, and this is the marking sheet that we're going to use. And I think we're going to use the same today. You can see the practice management will be tested in both panels, by both panels, okay? So this is the second panel for long-term skills, proficiency in investigations, and ethics questions. And so this is the rubric. Maybe I can drag your attention to the borderline. So borderline is basically when you decide a candidate is a borderline, the mark should be around 12 to 13 out of 25. Okay, and I think from time to time it's good to go back to this rubric to just make sure that we are on the right track. and sandwiching the borderline is basically meet expectations or below expectations, and hopefully you're not getting any poor candidate during the re-exam. And occasionally I think we would see some with above expectations. I think that's it. Any question? Otherwise, I pass to Prof. Azida to continue with the proper PD calibration for today. Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh.
Okay, thank you, Dr. Imran. So I just share my. Thank you, Dr. Imran. Assalamualaikum warahmatullahi wabarakatuh. Good morning. Salam sejahtera, everyone. Dalam satu Ramadan, we are almost finishing Ramadan. InsyaAllah, we're going to celebrate Hari Raya soon. So it's going to be just a very brief PD calibration briefing. The word is briefing. So these are the groups that has organized this PD calibration today. And so the objective of the PD calibration, I think most importantly, is to build a clear understanding in the use of the grid marking scale and rubric scale among the examiners. And I think this is the time that the most experienced, examiners shared their experience and guiding the new ones, especially. Every semester, we'll have a new examiners coming in. So I think it's very important that this PD calibration keep on to guide the new generations of examiners. So it is improve the inter-rater reliability, okay, and to discuss on the PD performance standards, that is clear fail, borderline, or clear pass, and to introduce the process of the virtual part 3 PD Viva. So these are the just the event shortly. So after the briefing, we will have 2 videos. First, we start with the panel 1. Then we have the calibration and discussion. We have a very short break, 5 minutes break before we begin with the video 2. Is the panel 2. Then we have the calibration discussion, and lastly the summary of the calibration workshop. And after that, Prof. Rosdiani will take over to give the part 3 examiners briefing, and then we will, log out of this Zoom meeting and join the meeting for the mock practice diary examinations for the examiners. So briefly, there's a slight changes I made compared to the other PD calibration. It's just that it's 2 videos. Simulate the exact exams, panel 1 and panel 2. But it's just I said simulate because in real exams, when you make assessment, it's based on 30 minutes. But what we're going to do today is only 20 minutes. So just give the marks basically for that videos only. Because in exam, perhaps you have more cases that you can assess the candidate more thoroughly. But it's just that for this simulation, it's only 20 minutes. So everyone is given the Google Drive, where we got the cases, mark sheet, and rubric. Now, just for the purpose of PD calibration technique, I've used the sharing of the candidates' cases during the videos. So when actually you are watching these videos, you don't have to open up the cases that I've shared. Everything is in just the videos. Just concentrate the videos. So as the candidate are being vivaed, the cases were shared in the videos. But just to remind you, in real exam, there won't be any sharing of the PD calibration during the actual viva. Okay, so take note for the examiners. And the other thing is that by the end of that, after the videos, we have about 5 minutes for the examiners to give the marks. And during this time, you also don't have to open up the mark sheet and the rubric because we will share the mark sheet and the rubric in the Zoom. So you just actually just have to think about the marks. But then after that, you need to go to the Google Sheet to put the marks. So actually, there's many steps that I think can cut short to ease the examiners. And for those who have problems in, sometimes, yeah, you have problems to access the Google Sheet. What you can do is put the marks in the chat. Just put your names, put the marks. You say pre-discussion marks. Or you put your name, post-discussion marks. So that we can help you, Dr. Yin Yin will help and put your marks inside the Google Sheet. So there are many ways. I think I've tried to ease the examiners and the co-markers in these online PD calibrations. Okay? So remember, after the videos, you give your pre-discussion marks, fill in the Excel sheet next to your name, and do not discuss yet. Then after that, we will open the floor for discussion. You give your post-discussion marks. Okay? All right. So just a reminder for the panel 1 and the panel 2. So the panel 1, we start first, the first videos, and the score rubrics. So that's all for my briefings. Any questions?
Assalamualaikum, Prof.
Waalaikumsalam.
Can Ilham here, boleh nak tanya?
Yes,
Sebab
yes,
total, I'm not sure whether I open the right Google Marks tu sebab dia ada total je. So for practice purposes, selama ni kalau kita buat practice lari calibration, kita ada komponen-komponen juga untuk the new ones tu. Macam practice management berapa, semua berapa, so tak boleh learn. So
there are about, I understand, because there are about 60 participants. 60 participants, and to open up the Google Sheet to individualize those marks would be like quite massive. So that's why what I will do is that we will ask the examiners, we will put up this kind of things. So you put yourself those in the marks awarded. So during this discussion, let's say when I call up, then you will say, oh, I give 50, skill practice management berapa? 13, that's all. Because as times goes by, the participants punya list is like, a lot, about 60. So to individualize the marks takes quite a massive kind of Excel sheet. So that's why we have just summarized and compressed it into one. Okay. So maybe someone can tell us how to do it with like 60, 70 participants. That's all.
Okay, good morning. Can you tell me your blinded number?
Good morning, examiner. My blinded number is 001.
Okay, I'm Dr. Aziza Abdul Kadir.
I'm Dr. Aslina.
So we will begin with practice management. So can you tell me one problem in your clinic that you want to improve?
I'm currently practicing at Klinik Kesihatan Wakabaru. During this COVID-19 pandemic, many services in my clinic are affected. One of it is men's clinic service. It's not running well during this COVID-19 pandemic. The problem that I identify can be divided into staff factor, system factor, and also patient factor. For the staff factor, actually we lack of staff to run this men's clinic, as few of the staff actually has been chosen to involve in the COVID activities such as vaccination, fever clinic, and then swabbing. And we also have a few young doctors actually lack of knowledge to handle these men's problems. For the system factor, so far there is no proper flow chart of the men's clinic. And for the patient factors, patient actually default follow up during this COVID-19 pandemic.
Okay, can you tell me why you choose to improve the men's clinic?
This problem actually is high prevalent, especially among the diabetic patient, and this problem actually is under-recognized and not treated well, as men's problem actually can affect the patient quality of life. Furthermore, actually, many of our patients actually trying to seek help and they buy the black market medication to solve their problem. They actually didn't realize that how dangerous of this medication, because some of the medication, this medication actually might interact with other medication that prescribed by the doctors and also may affect their kidney and also liver function.
Okay then, how do you plan to improve?
For the staff problem, then I will do meeting with the staff and with the previous team, and then identify a problem, and then we will decide to run the men's clinic again, and also we're reshuffling the staff because currently actually less busy due to the COVID. And then for the young doctors, then we will run a CME, and even though actually the men's clinic actually run quite some time, so far there is no proper flow chart. So we will do a flow chart of this men's clinic on how to recruit the patient, and then after that we'll place at the doctor's rooms. And for the patient wise, we will screen the patient during the appointment, TCA, the diabetic, and also OPD clinic. Yeah.
All right. You mentioned that you have many young doctors. So how do you plan to conduct the CME for them?
Okay, we plan to do the CME once a month in the clinic among the team members, especially when the clinic is not busy. And we also plan to do the topic of the CME that focusing on the aspect that doctor not familiar with. And then we also will send the staff for the course outside or attachment at the men's clinic at established center. And we also will look for any micro-credential course that available online, and then we'll ask my team to join during their free time, example like weekend, and also get the certificate.
So how you ensure that all these activities, the CME's activities is successful?
If the staff is competent to handle this men's clinic, I think it's considered successful enough. Of course, we will do the assessment on the staff from time to time, and also to ensure that the staff that complete the micro-credential course and get the certificate.
Okay, you mentioned just now you want to do the CME among those team that manage men's clinic only, not to all the staff. Okay, can you explain?
I think we need to educate the team involved first, then only involve other staff. And then we will run the CME during like not busy time during weekend like that.
Okay, you mentioned that the flow chart was not proper. Okay, can you tell me how you want to improve that?
As previously there is no like screening for the patient, screening erectile dysfunction among the patient. So, and then if the patient complain only, then we refer to men's clinic. So we plan to do the flow chart, like we plan to screen the patient at the triage by using the IIE F5 questionnaire for the patient to fill in while waiting for the to be called into the doctor rooms. And then after that, the doctor will review the form.
Okay, then what will you do?
And then after the doctor review the form, then based on the questionnaire, if the patient have any problem with like erectile dysfunction, then we will give the appointment to the men's clinic if patient agree. As our men's clinic actually will run every Tuesday.
Okay, you said that patient defaulted follow-up, right? How do you want to improve that?
Okay, we will appoint a staff to call a patient, and then inquire what's the reason that patient's not coming, and give another follow-up, and then to ensure that the patient not default again, so we will call a patient the day before the appointment.
Okay, so what do you anticipate from this?
One problem that we anticipate is we don't have the contact number of the patient, and also the staff is too busy to call.
Okay. Now, you said you want to do many interventions to improve the men's clinic. So how you monitor the successful of your intervention?
Okay, there are a few criteria actually to measure the successful of the intervention, and this criteria actually should be measurable, then clear, and then can be achieved. If possible, we should use the standard criteria set by the JKN or based on the national target set by the Ministry of Health. So far, there is no any standard indicator set by local authorities regarding this men's clinic. So I will discuss with the team in charge for a suitable target. Maybe we will decide to monitor the increment of the new patient that recruit in this men's clinic per month, around 10% like that. And then the denominator will be the total number of patients that attending this men's clinic.
Okay, candidate, can we move to the case 1 next?
Okay.
All right. Now, can you tell me why you start this patient on perindopril?
As this patient has type 2 diabetic with proteinuria, so I start the peridopil, which is the antiproteinuric agent, although that the patient BP is normal. So I start with a low dose.
Okay, what will you anticipate when you start this medication?
The patient BP will be lower. However, I will advise the patient to monitor her BP at home. If she is symptomatic of low blood pressure, then I will advise the patient to come to the clinic immediately.
Okay, let's say if you encounter a diabetic kidney disease patients who had episodes of proteinuria for the first time, how you will approach the patient or manage the patient?
Okay, if the patient come with the first episode of proteinuria, I will repeat the urine microalbumin, and then we'll repeat like in 2 to 3 months time. If persistent, more than two episode if persistent means positive in 2 occasions, then you confirm that patient have proteinuria, and then we'll do the quantify the proteinuria and manage accordingly.
Okay, how do you know that that proteinuria is due to diabetic kidney disease or other causes?
Okay. I aware that there are many causes of albuminuria, such as pregnancy, UTI, diabetic, heart failure, and this patient also going for gym, maybe the causes of the albuminuria. In this patient, actually patient is asymptomatic of UTI, so I don't think it's so we can rule out the UTI. And then patient have regular menses, did not complain of missed menses, so there is no pregnancy. And patient also have no any sign and symptom of heart failure. So most likely causes of albuminuria in this patient is due to the diabetic.
Okay, I noticed that you started this patient on perindopril 2 milligram for anti-proteinuria effect. Okay, so do you think the dose is enough?
Okay, I'm not sure regarding the dose that needed to treat the microalbuminemia in a normotensive diabetic patient, as most of the evidence actually has been done is among the hypertensive diabetic patient. But I think there is still evidence or studies show that ACE inhibitor actually is indicated for normotensive diabetic patient with proteinuria. So for this patient, I will after start the ACE inhibitor, then I will check the albumin creatinine ratio to look for whether there is any still have proteinuria. Then I will slowly titrate the peritopil and then to a maximum tolerated dose.
Okay, is there any other medication that you can consider?
ARB.
Any specific ARV that you know or any study that you can use to support that?
I will start irbesartan, but I'm not sure about the study.
Okay, why do you consider ACE inhibitor in this patient rather than ARV?
This is because the ACE inhibitor actually is a first line drug and is much cheaper compared to ARB.
Okay. Any other factors that you should consider when prescribing a medication?
Other factor that we should consider, like such as the availability of the drug, and then the cost effectiveness, and then the indication and side effect of the medication.
Okay. Is there any other option for the treatment for the diabetic kidney disease other than what you have mentioned, ACE inhibitor or ARB?
Currently, we have the SGLT2 inhibitor, which is recommended for diabetic kidney disease, example like empagliflozin, but however, it's not available at Klinik Kesihatan.
Okay. I noticed that you plan to repeat the renal function test within 2 weeks. May I know why?
I would like because I want to monitor the creatinine level because I start the patient on the peritopia ACE inhibitor.
Okay, let's say the creatinine level is increased 20% in 2 weeks. What will you do next?
I will monitor the creatinine level in another two week, and then after that, to if the creatinine is more than 30% increase, then I will withhold the peritopia, and then we'll send the patient for renal ultrasound Doppler to rule out renal artery stenosis.
Okay, so let's move on to case number 2.
Okay.
Okay, can you tell me how you treat acute pain in this patient?
I will treat the pain first according to the pain score. In this patient, actually, the pain score is 5/10, which is moderate pain. So I prescribe this patient with regular paracetamol.
Okay, if the patient pain is not controlled with this regular paracetamol, how would you manage the patient?
Then I will give the NSAID as needed, top up with the paracetamol. Example like Warfarin, 50 milligram PRN. If the patient have not any contraindications such as history of fatty ulcer disease, CKD, or allergic.
Why did you choose Warfarin? Can you justify?
This because the availability of this Warfarin in my clinic, and I'm familiar with it. So far, among all the NSAID, there's no difference in terms of efficacy.
Anything else you should consider when starting NSAID?
This patient actually is considered young, and so far she has no any risk for cardiovascular disease. She is non-obese, and all the parameters were normal. So I think she has no any contraindication to start NSAID.
Okay, for any patient with kidney OA, what are the other measures or treatment that you can give to reduce the pain?
I can also advise the patients to use like cold compression, especially during the acute flare-up, and also we prescribe a patient on a topical application such as like ketoprofen gel, LMS.
Any other options?
Uh, I will also consider tramadol on top of paracetamol. And then patient who is on NSAID actually by we adding the tramadol actually more effective on pain relief as mentioned in the CBG of osteoarthritis.
Okay, what are the common issues with this medication?
Since patient actually is working as a teacher, so I will advise regarding the side effect of tramadol, such as drowsiness, nausea, vomiting, constipation. I will advise the patient to take the tramadol at night, as this drug will cause drowsiness.
Okay, candidate, can we move to case 3? All right. Now, looking at this patient as a whole, what important aspect of care you should assess?
Okay, by looking the patient as whole, I will ensure that his medical conditions, such as hypertension, hyperlipidemia, are well controlled, and there is no complication, no side effect from the medication, and then patient is compliant to the treatment and also follow up. Looking that he's an elderly, then I would like to screen him on the for the cancer, such as prostate cancer, as he has the load symptom currently. And I also will screen the patient for any dementia with the MMSE.
Okay. Now let's say the patient's son complained that his father has multiple falls previously. So how do you go about it?
I will do the fall assessment on this patient. Since this patient has hypertension and on alfuzosin, which is an alpha blocker, I will check for any postural hypotension for this patient, check the BP standing and also sitting. I also will check for his balance, do the times up and go test, check for the vision problem, any joint problem, and then any gait instability, and also we look for like muscle, lower limb weakness.
Okay. Anything else you like to do before that?
Uh, I will assess the patient, the history of fall first, because I want to identify the cause and to ask for any complication from the previous fall, such as like fracture or any head injury.
Okay, what are the possible risk factors of fall in this patient?
Postural hypertension is one of the risk factor as for this patient, as I mentioned, and then and also this patient actually is using the walking stick when walking, which actually brought from the pharmacy. The inappropriate use of this walking stick actually can be one of the cause.
Is there anything else?
Mm, my patient actually is on the hydrochlorothiazide and she has the BPH. So he will visit the toilet frequently together with his walking problem. And all this I think is the risk, all the risks that contribute to fall.
So, knowing that, how do you manage the problem?
I will adjust his antihypertensive medication by like optimize his peridopil to 8 milligram and then of the hydrochlorothiazide. I also will monitor his blood pressure, will monitor his blood pressure and also advise patient to monitor his blood pressure at home and advise for any hypertension. Then I will refer a patient for physiotherapy, for muscle strengthening, and also refer to occupational therapy for a proper walking stick. Then furthermore, we can do the home visit, arrange a home visit to assess any other factor that can contribute to fall, such as the environmental factors.
All right, student, the time is up. Thank you.
Thank
Thank
you.
you.
Okay, everyone. Now you get about 5 minutes to think about to mark these videos, and Dr. Yin will share the rubric and the marking forms for the panel one. Okay. So, to all the participants, this is the marking forms for the panel one and the rubric for markings to ease you in thinking the marks. So, you don't have to open up the Google Sheet, but once you have finalized your mark, please put the marks in the practice management, short-term care, and then total up, because we use the marks for this discussion later on. Then you can put the marks in the, we will show the marks in the marking sheet.
we just put the total marks only, isn't it?
Yes, you put the total marks only, but then please also keep the domains, okay, for your, jot it somewhere. So because later on, we will use that for discussions. Okay.
Prof. Hasidah, may I suggest to just add the columns inside the Excel so that we don't have to jot anywhere, just jot in the Excel.
I don't know whether Dr. Yin Yin can do that for everyone in just a
Yes.
short time.
Very easy, just add column je. Column 1, practice management. Column 2, short term care. Lepas tu total is still there if you want to discuss on total. I can help you add if you want also.
Okay, wait, Dr. Yin Yin, can you open up the graphs? Actually, if we do that, it will disrupt this graph. Because I cannot observe all 50 participants in that one Excel sheet. So I will just look at this graph and see the tabulations of the total marks. So if you do that, it will be quite, the graph will be, does it disrupt the graph? Macam mana?
We're not sure if it's going to disrupt the graph, but Prof. Sharina is also typing something. Sorry, mic is not working. But if you put on the columns, add columns je, and then it will not kacau your total sepatutnya. Maybe
Yeah, okay. Dr. Gigin will do that. Yeah. Okay, no. She doesn't know. So, who are willing to help us in putting up that column? Maybe you open up the sharing the other. Who can help the total before the total mark? Just add the column there. Can someone just edit that? Right. Thank you very much. Okay, so those who has fill in your marks later on, you can put the marks in the column. Okay. Okay, everyone. We almost 5 minutes. There's still a few I think did not fill in their marks. Okay. Mungkin yang tu tak hadir kot. I assume. Okay. Alright. Can we?
Assalamualaikum Prof. Azida.
Waalaikumsalam. Yes.
Anif here. I'm not able to put in my marks into the Excel. Can you help me do this?
Just put it in the chat, Anis.
Okay, and then
You
you all
just
will...
put practice management berapa-berapa, nanti Dr. Yijin akan masukkan.
Okay, Dr. Ying Ying, can you put 15 for all components and total marks is 60?
Wait, you look for your name first. Kejap Anis, kejap. UITM.
UITM.
UITM, Dr. Yijin, UITM. Okay. There's someone has put in for you. Is that right?
Okay, great. Okay, so 15 and then 60 total. Thank you.
Betul. Okay. Alright. I think then it's difficult to see like this. Can open up the charts. Okay. Looking at the charts, okay. I don't know yang 17 tu, 17 tu siapa? Prof Norita.
I tengah nak masuk kan.
Okay, alright.
Can you allow me sebab dia start.
Oh, why don't you just
I
say it
only
out
allow
loud?
one. Okay.
Okay, tunjuk tu isi tu. Alright, UM.
Okay, I can enter now. Nanti kejap I letak
Alright, we'll wait for you. Alright. Zero tu maksudnya tak isi lah. Okay. Okay, looking at this chart, perhaps we go to, I think the lowest would be around 57. 57? Yeah, 50. Prof. Sharina, would you like to give a comment? Ke Prof. Sharina ada masalah dengan mic tadi? 57? Oh my, alright. Then we go to 59 lah. 59 siapa? Prof. Chiu Bunhao, co-marker. Oh, co-marker. Alright, so we are not good. Prof. Iskandar, I will go for 60, I think. 60. Aznida, Prof. Aznida, would you like to give your comment?
Okay. Assalamualaikum.
Waalaikumsalam.
Okay, so basically I felt that the candidate just met the expectations, but it's definitely, she's not a borderline and definitely she's not an above expectations because most of her responses were not backed by evidence, and she just thought about what is required, and there is in terms of practice management I find that the recommendations were actually kind of generic and just meeting the expectation. She's not excellent, but this is a worker, a person with the potential to be fine-tuned during the examination period. So, but she is a pass candidate.
All right, thank you. Okay, Prof. Aznida. Okay, now I would like to open the floor for anyone who wants to make the comments. Anyone would like to make the comments about this panel 1 candidate?
Prof. Aznida, Adina here.
Yes.
So I always struggle with how much the examiners ask a question that give ideas to the candidate lah. Because I think for some of the questions, especially in the pain management as well as the short-term care. Some of the examiner's questions are a little bit leading, so I find it very difficult to mark if that's the case. You know, whether it's coming from the candidate or is it because the examiner, the way that we phrase our questions. I mean, I'm guilty of doing that as well, but I'm just would like to point out that thing lah. And I agree with Prof. Aznida as well in terms of she said a lot of things, but whether it is backed by evidence or whether it is applicable to the patient is a bit questionable. Thanks.
Thank you. Yes.
Azah here, Professor from UKM.
Yes.
Yeah, it's a borderline, but what I would like to point is that the time spent for one question, maybe this is a training, but just for everybody, the time spent for one question is too long for one component. Let's say for the prescribing habit for very long, going too long and going to the investigation as well, where else that we know that the investigation going to be asked in the second panel. The reason why I mentioned this is that sometimes the student might not be able to grasp or not be able to give a good answer at the first case, but we the examiner, we should give another chance to another questions with the same domain is possible, so that we can actually see the breadth of how actually the student responds to the same domain in as many patients as possible, so that we usually carried away want to dig and dig and dig to what we want the student to answer to. If the student we feel that this is how the student answer for the first question, we move on to another question, to another cases, so that we have the breadth. Then at the end, then we can see, memang macam ni lah student ni, dia memang he gave only the superficial without any reasoning to it. Is she safe enough to practice? Is she a pass student or the fail student? So we must not be carried away, I think, in asking in a particular cases. Maybe the cases is not it's not as reflective of what she's doing for the whole practice for the whole practice diary. That's all. Thanks.
Okay, thank you, Prof. Azhar. Prof. Sharina and Prof. Sonaza. Yeah.
Okay, good. So anyway, I agree with what Aznida was saying, because her answers are too very general. It's not up to the final year level, certainly not someone who spent some time in KK. The questioning, I had trouble giving marks for the last one because about the falls, because it doesn't fall within panel 1. It's not really prevention, it's more of chronic disease care. So I think I couldn't give marks for that one. So I think it was Azhar who said the questioning is important, and I agreed about the Pandipril being too long on that. So I think it's more important to ask open-ended question rather than how do you, what do you, rather, because then it's leading the candidates to answer what you want. So it's not exploring about where they go. So sometimes a practice diary is better to talk less but listen more and see where they're going.
Okay, thank you, Prof. Sharina. Yeah.
Yeah,
Yes,
I agree with Prof. Azhar, because I struggle to give marks in the acute domain because I felt that there wasn't enough cases or different cases to assess that domain. So I think when we're actually examining, it's really important, as Prof. Azhar said, that we have to, if the candidate struggles to answer in one, then we move on and try to get them to answer in something else in that domain, so that it could be in that area, in that particular case, that there's a struggle, but they could answer better in another case. So you get kind of like a broader spectrum of the candidate's ability, rather than to just focus on one thing that might be a problem for them. We take that into consideration, of course, that they have a problem in that area, but you want to assess that they may have that there's a broader assessment of those areas. Thank you.
Okay, thank you. All right. Anyone else want to give comment?
Assalamualaikum, Prof. I just want to
Yes.
declare why I give prescription among the lowest. The reason I gave just to declare that although her pain management for OA is quite reasonable with regards to trying to increase the strength and different type of medication. But when we look back at the case of this patient who's on phenobarb, so she mentioned about, tramadol would be appropriate, not mentioning about the interaction between tramadol and phenobarb, which can cause drowsiness and all. So that's the reason why I did not give as high as the others.
Okay, thank you very much.
I think
yes.
one more just last reminder. I think just going back on what Fanaza said just now, I think it's important that we actually use the session to test the candidate on what they know and not grind them to death on what they don't know. So they don't know, then kita kena move on lah. But I think sometimes some people get carried away, like they keep on hitting on the candidate to actually, prompting and all that, hoping that the candidate would be reminded lah. But I think that actually eats up the time on us testing what the candidate does know and perhaps does it excellently.
All right. Can we just get a comment from those who give like 70 or 71? We have this Dr. Iskandar. Dr. Iskandar, would you like to give your comment?
Yes, but first, can I just clarify? When you move from one case to one case, is it moving from one domain to another domain?
Not necessary.
Okay, so it can be a mix up. In one case, it can be a mix of all the domains or maybe some of the domains.
Yes, yes.
Okay, and then when we talk about practice management, is it in accordance with the first 30 cases in panel 1, or it is according to their practice? I mean, what are you looking at?
Okay, the practice management actually is not looking at the cases, it's looking at their practice.
Okay. Well, coming back to the question, leading question, for example, actually the best is open-ended, but then again, if you move, what we call, if you justify, for example, you clarify to the candidate, okay, this is pertaining to prescription, then you ask an open-ended question, then there will be no leading question. But if you mix everything, so it's a bit difficult, even as a marker, so it's a bit difficult. Okay, coming back to my marks, number 1 is practice management. Actually, being able to identify there is an issue with the system as well as with the staff, I think it's good. And then being able to come up with a solution, especially coming up with a management flow chart, even though we are unable to assess, because sometimes they say they would come up with the management flow chart, but yet the flow chart is not as expected. But it doesn't matter, as long as they can come out, it's very good, because in clinic kesihatan, she's not alone, so there will be multiple level of staff. So this helps a lot. So to me, if she's able to do that, means she's able to use the resources, thinking about I'm not going to see this patient from the very beginning alone, and the patient will come and then being seen by MO, maybe by PPP, and then so what would be the flow chart for them? That's the reason why I give 5 marks for the first panel. The second one is regarding, let me check again, in short-term care. Normally my impression for short-term care would be pain management. Okay, pain or cough or red eyes, so on and so forth. So I think normally when we're given practice diary, we look at the cases, and then we look at, for example, short-term care. What will be the trend? So if you identify that, oh, she has been doing like this, then we would like to clarify. Then we take one case rather than going from one case to another case. We take that as an example to clarify why did she do it. And that's my opinion lah. So I think my prescription is on the both for the pain as well as for the what we call ACE inhibitor, especially in diabetic patient. Even though 2 milligram is a chicken dose, actually it doesn't do anything, but at least she's going for ACE inhibitor, which we would like to encourage our MO to do that. Now their preference is calcium channel blocker rather than ACE inhibitor or ARB. So and then coming back to the next domain would be on proficiency in prescribing habits. Proficiency in prescribing habits. Actually, it's a bit difficult how to assess the proficiency, even for pain management, especially in chronic pain, from WHO analgesic level. NSAIDs and paracetamol sits at the same level, meaning to say that efficacy is the same. The only difference is that the frequency, where paracetamol use it every 6 hourly or 4 hourly, and then certain NSAIDs you can use it 8 hourly or maybe 12 hourly, or maybe daily dosing. But efficiency-wise, it is the same. However, they are allowed to use at a chunk. For example, regular NSAID with breakthrough pain paracetamol. And then last is regarding the prevention. I suppose the prevention is on fall. It's totally on fall. She's able to identify, and then she's able to what we call perform the assessment for fall. But when it comes to managing, I think she's a bit lacking. That's the reason why I think the lowest marks for me is on the prevention. But I give high marks on the practice management because of what I've said just now. Thank you.
Okay, thank you, Dr. Iskandar. I think the time is up now. So I would like you all to put the marks for the post discussions. Okay, thank you for the comments. Can you put the marks for the post discussion in the Google Sheet?
Salam Prof Azida. Minta somebody addkan mark saya 60. I cannot click.
Yes, sure.
Thanks, Mazah here.
You put it? Okay. Yeah, someone else has helped you. Thank you very much.
Thank you. Ilham ke tu?
I don't know who. Mystery.
Rosnani.
Oh, Rosnani. Thank you, Dr. Rosnani.
Ada orang lagi laju pada saya, Dr. Mazhar.
Okay, here I think it's good to see the charts, the trend of the charts. I would like to comment that I think on the average, the marks difference is about 10, over 60 to 70 for the pre-discussions. So when we look at the post-discussions, usually there's not much changes. So I think the the internal iterator or the iterator external is not much difference lah. I would see it from here. So actually, I think it's quite macam alright lah. Kita tidak terlalu jauh antara satu sama lain kan. Not much of big difference based on the whatever videos that we observed just now. So, all right. Thank you, everyone. So we will now share the second video. Oh, sorry. We have a break, 5 minutes break. Okay, have 5 minutes break. Okay, Dr. Yin was saying she want to give 10 minutes break. So I would like to ask whether all of you nak 5 minutes ke nak 10 minutes break?
And please.
Go, Kanida.
Okay je. Alright, then.
Jasmine tak 10. Alright. So we start at 10 o'clock. Okay, take care. Thank you, everyone.